Hi, welcome back, folks. If you didn't see the first edition of my little online diary about coronavirus and COVID-19, I talked a little bit about the introduction to the disease last time, trying to give a little bit of a pre-hospital flavor to this thing. But today I'm going to talk a little bit about volume and what this is going to do to the healthcare industry and why we need to be a little bit concerned about COVID-19 as a potential threat to your operation. So I have some stuff to talk about, but if you didn't get to see the first episode, I have a little rating system that I like to put up here because I want the data to be kind of consistent and honestly just of good quality and reasonable evidence. So where I feel like there's good evidence, I gave 3 thumbs up. Where I felt that there was some evidence, maybe like a publication from a pretty prestigious publisher or journal or something along those lines, but not a lot of peer support, that would be like a 2 thumbs up. Where it's anecdotal, meaning it's a video or, one source and maybe kind of questionable source, just 1 thumbs up. And then when I feel people are just being absurd and crazy, I put the little tinfoil hat lady. She has not made an appearance yet, but trust me, I have some content that I'd like to attach her to later. So it's coming. If you haven't seen the tinfoil hat lady and you're looking forward to that, I hope to present her for you. So numbers from worldometers.com, as you can see, still look pretty significant. Currently infected cases 125,000, closed cases 93,000. Again, that puts total somewhere around 118-ish if my math is correct. Mild condition, again, most patients about 6 and serious or critical. As I said before, this data doesn't always account very well for the split between like a med-surg patient and ICU patient, so we'll talk more about that. That death rate also is a little bit inflated, although numbers yesterday from Italy were kind of crazy, so yeah, let's do that. Let's do the numbers here. So China is on the next day already, so they did not report in. I think I'll go highlighter today. So China's numbers, like you said, see here, are pretty considerable. Again, that's the epicenter of the thing. I do want to point out that Italy is a substantially smaller country, but is racking up almost 50% of the reported cases. I also want to point out that China's numbers are mostly nonsense, hidden by the Communist Party of China. So they report what they want. Honestly, I don't have a whole lot of faith in the numbers here. They would have you believe that they have 56 cases per 1 million of population, whereas Italy has 10 times that. So there is just a lot of nonsense going on with the reporting in China. So they were, again, the sort of front line in this thing. They probably took the hit for most of us and really gave us some data, but their numeric stuff there's just a ton of propaganda in it. I'll do something separate on politics later because it's just crazy and wacky. But again, the Italians just got crushed overnight. I mean, 4,200 new cases, just massive. 475 deaths. It's like 1%, over 1% of their total, 1.3% roughly of their total. That's just crazy numbers. Iran coming in with 1,100 new cases, almost 1,200. That's very considerable. Iran does not report serious or critical, so we have like a big blank there. Their fatalities are also pretty considerable, running at about 8-ish% off the top of my head. The pressure cooker of Europe right now is Spain and Germany. Spain is really struggling with this. They're just having a horrible time of it, as you can see from the figures. They've instituted a bunch of social stuff to try to close this down, mostly restrictions like everyone else has. But they're a little late to the game here. And they're really suffering quite a bit from it. The USA, we reported a bunch of new cases. This is, as you can see, a little less than a third of our total over the last 24 hours. That sort of suggests an increase in testing. So what that basically tells me is it looks like some of those test kits are getting out and we're starting to see some case reporting because we are incredibly low, like artificially low from non-testing. So while this looks encouraging compared to, say, in Iran or in Italy, some people speculate we have 10 times that many cases in reality. So again, I'm not one of speculation, but it's not encouraging. France, again, pretty considerable. The UK numbers are still pretty low, but their testing is not particularly aggressive either, so that's kind of questionable. South Korea seems to have a handle on this thing. They're really being pretty aggressive with their social measures. They also have a very, very sophisticated testing and contact tracing program, so they seem to be doing a really great job with this, as far as I can tell. Again, Europe's starting to see some pretty reasonable growth here, too. So these are all kind of interesting figures as you go ahead and look at this thing. Now, I wanted to talk about the split. The dreaded split. The split is my little term for the people who become affected and how it's going to impact us as healthcare workers and pre-hospital providers specifically. So I did some rough math. The math is admittedly rough. I will just talk about a couple of the items here and a little bit of science. This is mostly from my last presentation here, where we talk about the University of Minnesota, I believe, their study about the Chinese experience and where the volume lies. So the estimate, again, is that COVID-19 ends up affecting 60 to 80% of the population. In fact, Angela Merkel, not too long ago, told Germany to expect 70% of their population to get sick, meaning 70% of the total people in Germany. For my math, I'm going to stick to the 60, which is sort of the low end of this estimate. I want to say this is a WHO estimate, but it's in the ballpark from what people are talking about. Now, we know that 80% of the people affected end up with mild illness that they can treat at home without professional medical care. So this would presumably be like a bad cold or a flu. The patient gets fevers, they have body aches, they have general malaise, but for the most part don't need hospitalization. So you would probably expect the bulk of your younger population to be in this category. 15% of the people who get this end up as low acuity hospital admissions. So maybe they need some supplemental oxygen, some IV fluid. They may end up with a secondary bacterial pneumonia, which apparently is pretty common after your respiratory tract gets all irritated from COVID-19. So those folks end up needing just a regular hospital bed, isolation obviously, but not really intensive medical care. 5% of people end up as high acuity admissions in the ICU. Those are the folks, again, who have significant demands on the healthcare system. They're tubed and vented, they maybe have septic shock and need pressors, they maybe have organ dysfunction that needs care. So they end up taking up your ICU beds. It's probably the part that's trickiest because we don't have the vents. Nobody has the vents. I mean, they just don't exist. And about 2%-ish are fatalities. That number, again, is in some dispute. The World Health Organization number is higher than that. But again, they tend to use official figures, and a huge bulk of this is still in China. And the truth is, the Communist Party just lies. It's just true. Also, it's really hard to capture in every country. I'm really not knocking the Chinese here, but in every country, it's actually pretty difficult to capture the mild illness because those folks are not going to report for treatment and they're not going to end up getting counted. So again, I suspect that the actual number is lower than 3%. People float 2.5, somewhere along those lines. But the 3.4, which I think is popular to float around now, I don't know. In either case, let's go with the optimistic numbers here for my little calculation. So I did a little bit of a mathematical model here on the service area that I work in. I did the number on the residents, and by the way, this is probably artificially low because I used the 2010 census for the municipalities we service, and I took some liberties because some of them are split with another jurisdiction, so we would have gotten half of that town's volume, so I just split it 50-50. This could be as much as like 230, 240,000 people. But those are the people that my EMS system that I work at primarily services as the main paramedic unit. 60% of that population gets sick, right? We went with the low end. So that means that we have 113,172 total infected patients. Yeah, it's a lot. When you plug in your own numbers to this, you come up with some fun facts that your manager would probably freak out at. Let's do a little bit more math. Again, we know 80% of those folks get mild illness. That's 90,537 cases. You would think the minor cases probably will not call the ambulance, right? Hopefully, maybe so. But knowing how people are, right? I'm seeing actually relatively, I worked last week and relatively few calls, completely anecdotal, of course. Also, census was fairly low in my facility, and I happen to know it was low in other facilities too. So it may be that people are avoiding the hospital, and frankly, it's reasonable to think that if you need your hip done or your knee done, you're going to put this off 6 months because you just don't want to go into the hospital with COVID-19 rampant. So I think a lot of people are deferring things, and in fact, a lot of our facilities locally have already said we're not doing elective surgeries unless basically they're not elective unless they're super acute. But mobile health volume, right? These people are sick at home. The doctors say don't come in. So the mobile health guys over to your house to check you out. So if you're doing community paramedicine / mobile health service / whatever you want to call EMS providers going to the house and checking up on people, yeah, that might be a thing. I'm talking to our manager about what kind of mobile integrated health we're going to be doing because we do that in my system. And I end up doing a lot of it personally. They're not sure. They're not sure how that's going to shake out yet. Whether we're going to see them, whether it's appropriate, whether we're just contaminating ourselves and dragging virus out. So some discussion about that right now. Okay, so low acuity admissions, almost 17,000. Yeah, I don't know where that volume comes from. We just don't have the beds. Our hospital services this area primarily. I mean, there are other hospitals, obviously, people can go to. They're fairly local, but nobody has 17,000 beds. I mean, the question is, over how long, but we'll talk about it. And then again, ICU beds, 5,658 by my math. That's a lot of beds. That's a lot of Levophed drips. The number is just sort of inconceivable to fathom because most ICUs are pretty small, and during influenza season, they run pretty full as it is. So, yikes. Okay, 2% fatality rate, again, ish. I sort of, tweaked the number a little to hopefully reflect my perception of reality, take it or leave it for whatever it's worth. But 2,263 deaths in my service area based on this. So, yeah, it's significant. And you may look at this and see the numbers and not really equate it to a personal impact. But let me show you something kind of interesting. I did the math on what that would reflect in the EMS system I work at. I took those 2,263 additional jobs, right? Additional EMS runs. And what I did was I broke them out over a 2-month period, which of course would be 60 days. That means we would get 37 additional jobs a day. Is that a lot? Well, it depends where you come from, right? This is a matter of perspective. If you work in a very rural system and you get 2 jobs a day, 37 additional jobs a day seems like the end of the world, some kind of number you can't fathom. If you're in a super metropolitan urban area, 37 jobs is Tuesday, right? That's not a big deal. So again, a little bit about perspective. Now, in my fairly suburban system, we have 4 transport-capable vehicles. 37 jobs a day divided by the 4 transport vehicles is 9.25 additional jobs per truck. And I did a little more math. They run 12-hour shifts. So that's 4.625 additional jobs per shift. So is it manageable? Sort of. I'm sure we can all envision our work volume, and maybe, depending on how busy you are, you might be able to envision another 4.5 jobs a day. However, additional variables. Can your system handle that, right? Well, could you handle it if you had 20 to 30% less staff? Because the second there's a pandemic, right, people get sick. And the estimate, in fact, the government told critical infrastructure providers that their contingency plan for pandemics has to include operations with 30% less staff because of sick outs and restrictions and quarantining and all of those things that tend to take people out of the trucks and into their sick beds or at home, staying at home. Can you do it with longer turnaround times? And what I mean here is maybe your hospital's diverting patients because they're up to their neck. Maybe your hospital is just super backed up, so the quick 10-minute turnaround you're used to becomes 20 or 25 minutes. And can you do it with all the PPE challenges you're likely to have? Because the supply chain is already a train wreck. I think that's my next one, actually, is supply chain, because there's just so much going on locally, and I'm sure each one of you guys has your own story about how you can't get this or you can't get that. But I have some genuinely interesting anecdotal data from local facilities and the challenges that they're having. It's just madness. So based on that, can you handle this? Is this volume realistic for your agency? It's really quite a bit. So I have an interesting historical reference for you. If you're not super familiar with Spanish flu in 1918, I may have made a reference to it in my last video. There is a really fascinating comparison of the death rates in Philadelphia and St. Louis in the 1918 Spanish flu. So for some historical context, again, 1918 is the end of World War One, right? So you got to imagine all these American soldiers coming back overseas in these crowded transport ships, just breathing and hacking and coughing all over each other and spreading this illness to each other. So a bunch of ill soldiers basically come in to Philadelphia first, right? Because it's the east coast of the USA. If you're not from the States, that's basically how it shakes out. And when they hit the east coast, they hit Philadelphia first. And what you see is this huge spike in cases, right? Because Philadelphia had no real social measures, right? They didn't take any precautions. So what ends up happening is all of the parties, all of the celebrations and parades, all of the day-to-day stuff, and I talked about this in the last video, but the schools, the places of worship, all these locations where people congregate, ended up spreading the disease like wildfire. Now, what's interesting is St. Louis is more interior compared to Philadelphia, right? It's in the inner part of the country. So these guys getting out of the ships in the East Coast had to travel inland, right? And it took a couple of weeks to do that because, it's 1918 and there's no air travel. And what ends up happening is St. Louis got a heads up, right? They knew what happened in Philadelphia. They knew there was a epidemic spreading, and they decided to shut the city down, right? No parties, no bars, no parades, no nothing. And what they did was they squashed transmission. Now, understand, this lasts a little longer, right? You see me with a highlighter here dragging this thing out. However, what they didn't do is get that big, huge spike. And that's really important because if you drag it out for a longer period of time, what you don't do is overwhelm your healthcare capacity, because your healthcare capacity is here, let's say, hypothetically. And if you get an increase, you can handle it as long as it doesn't go above that line. Because again, you don't run out of beds and vents and all of those things you need to treat patients. So the goal here in the United States, at least, has gone to maintaining social precautions, right? Like the social distancing and canceling events and ordering people not to go to work and canceling retail establishments and basically barring them from doing business. It's because that will ultimately prevent the spread, and that's really what you want to do. So this is referred to these days as flattening the curve. That's the goal, right? You want to take this peaked thing and you want to flatten it down. You want the cases to be more spread out so they don't overwhelm your healthcare system and don't end up costing you lives in the process. Because if you get a big spike, your healthcare system simply can't handle it. So flatten the curve is important. Flatten the curve is the plan. Flatten the curve is, how we beat this thing, at least for now, without putting a bunch of bodies in the ground. So this becomes the sort of rallying cry, if you will, the mantra of the pandemic is flatten the curve. So if you want to mess with your boss at your EMS agency, I will put a little COVID-19 volume calculator. In fact, let me just show it to you real fast because I've been messing around with this thing and I think it has some value here. So the way this thing works is it's an Excel spreadsheet, so naturally you would need Excel to mess around with this. But you can put in your population, right? And what it'll do is it'll automatically calculate your volume increases. Both your total patients, your increases by day, your increases by truck, and your increases by shift. So let's say you have, 3 EMS units. It'll auto-calculate your increases per shift. Let's say you don't work 12s, you guys work 8s, and you have 3 shifts. Cool, you can do that. Let's say you want to make it peak and go away in a smaller amount of time. It'll show you that. So this is kind of fun. It's not particularly scientific. It's just basic math with Excel. But I don't know. It kind of has some modeling value, I think, just to kind of mess around with. So I'll put the link in there. You're welcome to download it and plug in your own numbers if you happen to know them. And you can screenshot this and send it to your manager. It might put them into a tizzy, but it also may create some like importance on this thing. So if your folks who run your EMS system are a little blasé about this and maybe not really thinking about this hard, this might just sort of sober them up a little and show them, the challenges that we're all going to have the next couple of weeks. So hopefully it's useful for you. And again, I'll put it in the link attached to this particular video. So I know I talked about this last time, but this thing's for real, all right? If people are kind of being blasé and just, talking about why are these fools all buying toilet paper, I don't really think toilet paper is the answer to this thing, but I do think it's because people are concerned, and rightfully so. I don't think it's something that we should all kind of like shrug at like it's nothing. So again, maybe next time PPE and supply chain, we'll talk a little bit about that. Okay. Good luck, folks. Stay safe.